cardiovascular events in CKD. The 40%, now even 30 to 50%, in fact, the CKD patients, they have cardiovascular morbidity and mortality. It is less common in the early stages, more common in the your late stages. In G2 and G4, 20 to 30%, and in the maintenance hemolysis CKD5, D and beyond, you have 80 to 90% patients who has some amount of CV events, left ventricular hypertrophy. Mostly your how these things develop because of the atherosclerotic plague by dyslipidemia on CKD and insulin resistance. Then you have uremic arteriosclerosis, diffuse calcification and calcified plaques, and the medial layer of the arteries, mostly advanced stages of CKD, are being affected, and where you have osteoblastic myoblastic transformation evidenced by the carotid intimal medial thickening and basal stiffness. That is, you have to go for an test in the internal jugular vein. And uremic cardiomyopathy is quite common. Hypertensive left ventricular hypertrophy is quite common. Fluid overload, non-cardiogenic pulmonary edema, and the compromised cardiac function is quite common. Diffuse intramyocardic fibrosis, diastolic dysfunction ultimately ensues in advanced CKD, and ultimately the commonest mode of death in CKD patients is the left ventricular dysfunction and your ultimately irreversible heart failure.